Is this how you feel waiting for your patient at the ER? With these slides, we hope to be able to give you a primer on the pediatric emergencies, and hope that you will be ready and confident not only to recognize commonly encountered conditions in the ER, but also to know what steps can be taken, when to refer, and to not panic. More than ever, your efficient pediatric history-taking skills will be utilized maximally now, since you are under time pressure and the conditions are no longer ideal for a relaxed and detailed interview. Please remember that there may be inter-institutional variations in management, especially that the ideal is not always practical, economical, nor available in the local setting. At several times, many emergencies are several overlapping conditions, and a judgment call can be made by the consultant or resident on duty. Suffice to know, though, at your level are the consensus guideline treatments and basics. Work your way from there. This reference is just the tip of the iceberg, so to say, in that your references, lecture notes in the college, and recent updates make for the best course of treatment. At this point, we can say that your stock knowledge can finally be applied in real-life situations. The ER is a high-intensity rotation. It is
One,
going to
two,
be one of the
three.
most taxing parts of your rotation. Hence, slacking off is not allowed and any free time should be used productively. Multitasking is necessary. Often, you might find yourselves interviewing a patient while doing the physical examination, simultaneously ushering and calming the patient's anxious parents, while composing your assessment and management in your head. Your assets are a targeted history and PE, as well as your presence of mind and quick decision-making. Sad to say, you will be asked to do scut work. What is that? It's also part of your learning process, but it's a little bit physical and tiring. Samples are writing your requests, following up the results of these labs, following up your patient's treatment, writing discharge instructions and prescriptions, and giving counseling and advice before the patient leaves the ER. You should be armed with your books and notes because knowledge is power. And fortunately, there are available digital versions of your textbooks. Some institutions have actually taken the step further to make them available literally to fit in your pocket as pocket references. Know or list down the numbers to the following areas. It will be useful when you are following up labs or looking for your resident if he or she is not yet at the ER. Be respectful with the ER staff. Do not be mean to them or your patients. Also, be ready to answer Q&As all the time. Always know who your Pedia ER resident is, where she or he can be found or contacted, and take note, never leave the ER without informing them or your immediate senior if you are about to leave the ER momentarily for a valid reason. In a nutshell, a typical flow of patients in the Pedia ER is as follows. The patient is assisted and ushered by a triage nurse or ER personnel towards the Pedia ER area, and you, as the Pedia clerk, has the responsibility to log in information to the blotter. This includes general data and entries from your short targeted history. With your short physical examination, you might also be able to assess already if this patient's case is something urgent or emergent. The Pedia ER resident must be informed immediately. If, however, your patient is stable, you can begin to administer first aid like antipyretics for fever or ORS for a patient who has diarrhea. Upon arrival of the resident at the patient's bed, the resident will verify or confirm your report and do verificatory physical examination and history questions. You can now relay your working impression to him or her and narrate your plans for the patient. The patient's diagnosis is established, he or she is stabilized, and orders for diagnostics and therapeutics are carried out. It is your job to follow them up. The patient now is either sent home and discharged or sent up to the wards for admission for further care. There are circumstances, though, that the primary managing department for a pediatric patient may be different, such as in the cases below. In general, any trauma or injury, any condition in need of suturing or casting is not directed towards the Pedia ER right away, as in the case of lacerations, puncture wounds, abrasions, and animal bites. Surgery gets to see these patients first and secondarily referred to us for medications. So what are the most likely emergencies in the pediatric department that you will encounter? Attention please, attention. Code 123 to the ER now. Code 123 to the ER now. Best chance of recovery from an out-of-hospital arrest is through an effective emergency response system with the most efficient team members, both knowledgeable and skilled in resuscitation. So the hospital makes an effort to make known an arrest to everyone available and able who can help in. Once an arrest or near-arrest patient is brought to the ER, a dedicated color-coded buzzer can be pressed, automatically triggering an announcement over the PA system. You might be that person closest to the buzzer, so know where it is located. All ER personnel and medical staff, even outside the ER, except in the intensive areas, are required to proceed to the site of the code within 30 to 60 seconds. The most senior medical personnel, either be it a resident, PGI, or medical clerk, must initially be the leader to initiate the ABCs for cardiorespiratory arrest resuscitation management. Upon arrival of the resident on duty of the department, say for instance the pedia resident, if there is a pediatric arrest, he or she must take over the leadership in management. Hence, all of you must have basic and updated knowledge of the BLS and for PEDIA, PALS, or Pediatric Advanced Life Support. If, say, you are on the sidelines during an arrest, make yourselves available for support. Your presence is still essential to insert IV, usher watchers, hand out equipment, crowd control, or as a substitute for the person doing compressions when he or she gets tired. Do you still remember? BLS and PALS memory really are skills that must be refreshed. So it is time to review the code algorithms in your lecture notes from the university. As a personal recommendation, I would like you to access learning materials and videos from the DISC Foundation, cited with the following link, or download the Medicode app, also by the same organization. It contains not just the algorithms, but includes practice videos and mega codes. These are also available through the playlist below through YouTube. These are screenshots from the actual app. Happy exploring! Falls with impact to the head are one of the most common pediatric injuries you will encounter, like falls from cribs, high chairs, or stairs while the patient is playing unsupervised. Most of them, though, are minor closed head injuries and concussions. Assess the patient for any surgically manageable lesions. If not, Pedia will manage him or her solely. Tips on what to ask in addition to standard history regarding the circumstances of the fall are the following, which, if positive, will prompt further diagnostics, intervention, and possibly admission. Ask about a recent post-injury history of amnesia, confusion, difficulty concentrating, disorientation, or in infants or preverbal children, persistent irritability or crying. Was there a verbalized or reported headache, dizziness, gait abnormality, sensitivity to light and noise, slurred speech, or excessive and inappropriate fatigue? Same is true with excessive sleepiness or emotional lability. Look at other symptoms in the GI, including nausea, vomiting, and refusal to feed. Ensure a short but comprehensive neuro exam. Assess the GCS of the patient too and refer to the following modified scale for children and infants. The following red flag signs should prompt an immediate referral to your resident. Signs of oncal herniation such as a blown pupil or irregularly sized pupils, findings of hemiplegia or flaccid muscle tone, hyperventilation and apnea or decorticate posturing. Watch also in your physical exam findings such as those of bleeding from the ears, hematoma around the eyes or behind the ears, or appearance of nasal blood or nasal CSF leakage are signs of basilar skull fracture. Immediate first aid for increased ICP include positioning and hyperventilating the patient. In most cases, though, treatment at the ER is supportive, with an ice pack that can be requested from the nurses or aides, and observation, ideally 4 to 6 hours. While waiting, the patient should be monitored for deterioration of neuro and other vital signs. This is a sample decision-making algorithm for head trauma from the Harriet Lane Handbook. Say for instance you have a 5-year-old patient who fell from a 6-foot ladder and hit his head on the ground. There were no open wounds. The mother reported one episode of vomiting on the way to the ER. Upon physical examination, there were no battle sign or raccoon's eye, and the patient appeared cooperative and coherent. His GCS was 15. On observation at the ER at the first hour, the patient started to get agitated and vomited 2 more times. What is the proper course of action? Do a CT scan and admit the patient. With regard to sports injuries, the following is the rest recommendation according to the different grades of concussion. A grade 1 will require 1 week, a grade 2 will require 2 weeks, and grade 3 4 weeks of no sports until considered asymptomatic. Shock. This is a state of inadequate oxygen and nutrient delivery to meet tissue demands. A patient who is pale, weak, dehydrated with a thready pulse is the typical picture of what we can recall with shock. This is another pediatric emergency necessitating immediate intervention. While compensated, patients are not yet hypotensive but already tachycardic, as cardiac output is attempted to be increased and shunted towards vital organs. Once this compensatory mechanism fails, the BP falls and a rapid cascade of events irreversible without treatment occurs. The most common and typical type is hypovolemic shock, as in the cases of dehydration, diarrhea, and burns. Other types are cardiogenic, distributive, obstructive. Septic and neurogenic types are sometimes under the classification of distributive shock. Administer oxygen and address the specific etiology of the shock accordingly. Fluids are generally the first line of treatment and boluses are necessary. Crystalloids, in the form of NSS, typically, are given at a starting dose of 10 ml per kilo per dose as fast drip or push. Vasopressors such as dopamine and dobutamine are given next. Other treatments that are relevant include the following. Severe systemic allergic reactions are the third topic. Anaphylaxis. This is an IgE-mediated hypersensitivity. The diagnosis is clinical. Here are the diagnostic criteria. Acute onset with skin and/or mucosal symptoms and with one of the following: respiratory compromise, hypotension, or altered mental state. Or two or more symptoms of the following occurring acutely after exposure to antigen: skin or mucosal signs, respiratory signs, GI signs, circulatory signs, and neurologic signs. Most reactions will occur 30 minutes within exposure, and these are the common etiologies. Ask if there were recent insect sting or animal exposure, recent medications or procedures, ingestion of allergic-inducing food, and ask also for the timing of the onset of the symptoms from exposure in your history. Therapeutics include assessing and addressing the patient's airway, breathing and circulation or ABCs, positioning and administration of IM epinephrine. And this is the first line of treatment at a dose of 0.01 mg per kilogram IM, maximum of 0.3 mg in kids, and 0.5 mg in teens. Epinephrine is an alpha and beta agonist that induces bronchodilation, vasoconstriction, and decreased vascular permeability. Monitor your patient's response and side effects, if any. Around 19% will require a second dose of epinephrine. Other adjunct treatments include diphenhydramine, ranitidine, salbutamol, and/or racemic epinephrine and steroids. Many Baguio residents are non-swimmers, and during the summer or vacation months, there may be several cases of drowning. On the other hand, drowning in bathtubs is also a common event in infants. There is respiratory impairment from submersion in liquid. Drowning is now classified either as fatal, non-fatal, or non-fatal with morbidity. And the morbidities can either be pulmonary, cardiac, neurologic, metabolic, hematologic, or renal. As little as 1 to 2 ml of aspiration of water can cause pulmonary vasoconstriction and impaired gas exchange. If, however, in the consideration of swallowing large amounts of water, this can cause laryngospasm to occur, causing loss of consciousness and hypoxemia, loss of circulation and tissue ischemia, and also CNS injury as a final outcome. The targeted history should attempt to establish the circumstances that led towards the drowning incident. Where was the drowning? How long was the submersion? What was the water temperature? Was there any precipitating condition, such as suicidal attempt, the use of alcohol? Was there abuse involved, or was there a pre-existing seizure disorder or epilepsy? The approach will require us to be extensive in our assessment of other associated trauma, including head and spine injuries and chest or abdominal trauma. You should also note in your physical examination these important points. CPR is initiated if required, airway is managed and maintained, shock is addressed. C-spine neck braces are applied, as neck injuries are quite common. Temperature management is unique to drowning injuries and is very important, as submersion in temperatures 20 degrees and below will induce hypothermia. Monitor the patient's vitals. and order initial labs that will be a guide for end organ morbidities. Burns. Burns are rampant among young children, and scalding etiology is the most common. Initial rapid assessment is key, and the information you need to gather is the type of burn by depth and the computation of the total body surface area burned. Techniques vary in the pediatric age group. The use of the Lund and Browder burn charts for children is preferred in the assessment of TBSA in most institutions. This diagram emphasizes how the same body part varies in terms of surface area among age groups. In the chart, shade the burned areas. Only the partial and full thickness burns or second and third degree by old nomenclature is included. In this example, say there's a 5-year-old with a fire burn. In the face, almost 3/4 of it is covered with second-degree burns. Cross-tabulate it against your table. A 5-year-old, the surface area A is 8.5% of body surface area. Doing simple computation, 0.75 times 8.5 is 6.4. Complete the rest of the computations and tabulations. This information will be important in consideration whether your patient needs to get admitted. The new list for admission requirements are as follows: 10% or more of total body surface area burn, presence of third-degree burns, sustaining electrical burns from high-tension wires or lightning burns, chemical burns, inhalation injury regardless of the actual BSA burned, inadequate social and environmental situations or difficulty for follow-up care, if child abuse or neglect is suspected, burns in the hands, face, perineum, genitalia, or major joints. Also, if a patient has a pre-existing medical condition that can complicate the acute recovery phase. Presence of fractures also is an indication. If you have more than 80% of TBSA burned, this requires a referral to a specialty burn unit or center, which unfortunately is not available in our city. What is the course of treatment for burns that did not require admission? Applying topical silver sulfadiazine and advising daily dressing until the wounds heal should be taught to the parents, guardians, and older patients. Follow-up is also important, as well as supplementation of pain control medications in the form of paracetamol or ibuprofen. In the Philippines, opioid analgesics are rarely prescribed. Whereas those that are admitted will require a multidisciplinary approach. At the ER setup, the importance of ABCs and fluids have been cited in the lecture slides given to you 3 months ago. Please review them. Next, there are patients who will present at the ER with a status epilepticus, a condition defined as seizure lasting for 30 minutes or multiple seizures occurring without return to baseline or regain of consciousness. It is important to establish the etiology of the seizures, and leading questions in the history should investigate on presence of infections, meningitis, meningoencephalitis, was there a history of trauma, compliance with therapy in known epileptics, is the etiology metabolic, were there signs of hypoglycemia, hyponatremia, hypocalcemia, were there diagnosed inborn errors of metabolism at birth, important to ask the results of a newborn screening. Is there any symptom of hypo or hyperaldosteronism, as in an adrenal crisis in a patient who has been continuously using high-dose steroids on a chronic basis? Toxicologic causes. Was the seizure caused by chemicals or drugs? Tricyclic antidepressants, isoniacids, fertilizers and insecticides, and heavy metals are the usual culprits. Is this a vascular problem, like a stroke, maybe a hypertensive episode, hypoxia, or a cardiovascular accident? While conducting a history and PE, initial management should already start. Secure the airway and position it to prevent aspiration of secretions. Administer oxygen and insert an IV line for medications and glucose administration. The common medications given are the following, and we'll observe a sequence. Initial seizure activity may be managed by administration of diazepam or midazolam. For prolonged seizures, the use of medications phenytoin or levetiracetam or valproic acid, all of them administered by IV. Continued seizures despite the above measures will trigger a referral for general anesthesia, and other supportive medications and treatments depending on etiology should be started. Poisoning is another lecture that has already been given to you. Please browse again your notes. I will stress, though, the importance of gathering data regarding what was the route, timing, was it chronic or acute, were there first aid measures done? Try to identify the poison. What were the active ingredients, the concentration, and the dose? If we will approximate how much was swallowed, we can make an approximation by computing it at 0.25 ml per kilogram. The expiry date of the medication and other ingestion of poisons is also important. What were the environmental predisposing factors for that poisoning to happen? These are the questions to ask. Is there a suspicion for abuse or Munchausen by proxy or suicidal attempt? Munchausen by proxy means that there is intentional hurting of the child which is facilitated by the administration of different chemicals, medicines, or poisons. Recall that poisoning diagnosis is mainly clinical. Poison blood level detection is not available in our hospital, and the laboratories that are ordered are rather to assess for end organ damage or computation of the anion gap, or blood pH that might identify the poisoning etiology and dictate management later. Recall that the combination of signs and symptoms in two toxidromes can help identify the etiology. Therefore, in your physical examination, focus on taking the BP and the heart rate and the temperature and assess for the neurological status of your patient, the pupillary size and response, whether there is presence of moist or dry skin and mucous membranes. Assess the bowel sounds and lung sounds. Washing and bathing of a patient exposed to environmental toxins and irrigation of the eye or mucous membranes with water is a type of decontamination, and so are the use of activated charcoal and whole body irrigation for ingested poisons. Remember that forced emesis and lavage are no longer routinely recommended. The dose of activated charcoal is such. In the case of more advanced elimination, the following can be done. The use of multi-dose activated charcoal, urinary alkalinization by administration of bicarb, or hemodialysis and exchange transfusion to eliminate those toxins like salicylates, methanol, and ethylene glycol. Treatment of poisoning is mainly supportive. Note that while there are antidotes, they may themselves be toxins and require careful administration and monitoring. Also, not all antidotes are available in our hospital setting. Treat all other associated effects of the poison symptomatically, such as seizures, hypotension, hyperpyrexia, electrolyte imbalances, and hypoglycemia. The most common toxic ingestion so far in our SLU experience is paracetamol or acetaminophen poisoning. The dose ingested is important to be assessed by history, especially since drug level determinations are not available in our institution. For children, hepatotoxicity is expected with a single intake of more than 200 milligrams per kilo per dose. Remember that the usual therapeutic dose given for fever or pain is just 10 to 15 milligrams per kilo per dose. On the other hand, for teens, the toxic dose is 7.5 to 10 grams as a single ingestion. Suggested laboratories to be carried out are the following: liver and renal function tests, and coagulation parameters. Admission is required if suicide is suspected or if ingestion is large enough to cause hepatotoxicity. The antidote to paracetamol poisoning is N-acetylcysteine. It is given at a loading dose of 140 milligrams per kilogram orally, then 70 milligrams per kilo every 4 hours for 17 more doses. NAC is not pleasant tasting, so improve its palatability and give an antiemetic too. For the rest of the common poisons, please refer to your lecture slides again. And finally, as the emergencies are already addressed and the patient prepares to leave the ER, please remind them regarding follow-up, vaccinations, and injury prevention. You are, as a pediatric clerk, a very important frontliner, and we value your participation in the health, safety, and well-being of our pediatric patients. With that said, good day, and I hope that you have learned something that you can take with you in your Pedia ER rotation. Thank you.